Good afternoon, everyone. I hope we have everyone ready for an exciting webinar today. My name is Diane Fabi King, and I am a Senior Public Health Advisor for the Bureau of Health Workforce, and I specifically work with the Division of National Health Service Corps, where we administrate the National Health Service Corps that hopefully some of you are there in those communities. Staying in the communities. And we hope that you will retain that and stay in the communities long after your service has completed. So with that, I would say thank you for coming to join us, and hopefully you'll tell other people about it and come back again for the next series. And I'll turn it back over to Malek. Thank you so much for having me.
Thank you, Diane, and good afternoon, everyone. Welcome again to the webinar, Addressing Clinician Burnout Starts with Organizational Change, How an FQHC in Rhode Island is Advancing Clinician Wellness. My name is Molly Mindbreast, Associate Director of NHSC Educational Programs at the Association of Clinicians for the Underserved, and I'll be your moderator for today. This webinar is brought to you by the National Health Service Corps Empowering Clinicians for Resiliency and Transformative Care Initiative, a project of the Health Resources and Services Administration, Bureau of Health Workforce. We're really happy that you all joined us today for the final webinar in our Fostering Resilience at the Organizational Level webinar series. Your presence today shows your dedication to clinician and organizational wellness, and we're so grateful you've taken time out of your busy day to join us. Our hope is that these trainings provide the knowledge and tools you all need to ensure NHSC participants are healthy and safe and have the energy and motivation to provide the highest quality care to their patients. So just to recap, in this webinar series, we've reviewed the 6 domains of evidence-based and promising practices shown to increase clinician well-being identified by the National Academy of Medicine. We explored the key skills needed for leadership staff to successfully navigate public health emergencies while supporting clinician well-being. We described how to protect clinician mental health. From the organizational level, we discussed how social support can bolster clinician well-being, and we provided practical strategies for creating opportunities for social support in the workplace. You can find recordings of all of the webinars and related materials from this series 2 on the webinar registration page, which we will post in the chat now. And the webinar recordings from the first series on clinician well-being and self-care can be found on our archived resources page, which we'll also post a link to in the chat. So for today's Grand Rounds presentation, we're really excited to have Dr. Matthew Malek to share his experiences and expertise with you all. Dr. Malek currently serves as the Medical Director of Clinician Wellness at Thundermist, a federally qualified health center in Rhode Island. He leads Thundermist's organizational approach to promoting clinician wellness, rooted in the 3 domains of clinical leadership, efficiency of practice, and community. Through his work, Thundermist became the first FQHC in the country to earn the Joy in Medicine Health System recognition from the American Medical Association. Dr. Malek is also a practicing family medicine physician and an assistant professor at the Alpert Medical School, Brown University, where he teaches in the Brown Family Medicine residency. Dr. Malek's presentation today will help you all apply the information and resources we've shared in this series on organizational approaches to support clinician well-being. He'll share the Thundermist plan for clinician wellness and talk you all through a case study of an intervention Thundermist implemented at one of their clinical sites to reduce burnout among a team of nurse practitioners. There will be lots of opportunities to engage with Dr. Malek and other attendees throughout the presentation through polling, the chat box, and by raising your hand to speak. Please, are we hoping you make use of these opportunities to interact with one another today? And before I hand the mic to Dr. Malek to get us started, I do want to go over a few housekeeping items with you all. The webinar is being recorded, and a link to the recording will be emailed to you all within 2 days. The PowerPoint slides can be found on the webinar registration page, which we linked to before and we can link to again. And the related documents and previously recorded webinars from the series are also available on that same page. This is a 2-hour webinar, and we'll have time for Q&A at the end of the presentation, but Dr. Malek will also try to answer questions as they come up throughout the presentation. So please type in questions you have for him in the chat box on the right side of your screen. You may have to manually open that chat box. If you look at the bottom right corner of the screen, you'll see the little chat icon, and if you open that up, you should be able to see the chat. And if you have a technical assistance question, please contact our colleague Josh. His contact info is going to be pasted in the chat as well. Polling will be used throughout the presentation using the Slido platform. You'll have 3 options for responding to polls. The first option would be to respond in the Slido box that should pop up on the right side of the webinar screen each time a new poll begins. The second option is to use your cell phone and take a picture of the QR code that will show up on the slide, and you'll have to enter in a passcode to respond. The third option will be to manually navigate to the Slido website using the URL that's provided on the slide, and you'll have to enter in a numeric code and a passcode. But once you've done that, for the first poll, you should not have to do it again if you keep your Slido window open. It'll automatically populate with the new polls. And finally, we just would love to hear your feedback on this presentation today. So do try to complete our evaluation survey at the end of the webinar to let us know how we did and how we can improve our training. So we'd really appreciate that. And to see closed captioning, click on the CC icon on the bottom left corner of the webinar window. And finally, Dr. Malek, I'll hand it over to you to begin our presentation.
Great, thank you, Molly, and thank you, Diane. And hello, everyone. Happy afternoon and good afternoon. I'm really happy to be here and joining you all. I'm excited that you've all been able to participate in this excellent series that's been going on. And nice to meet you. So as Molly said, I'm Dr. Matt Malek. I'm a family medicine doctor and the medical director of clinician wellness at Thundermist in Rhode Island. Before we get started on some of the content, I just want to say a word about Thundermist in particular, because I think context puts everything into helps us understand kind of what is going on and how it relates to where we may be. So Thundermist is a federally qualified health center. It's on the larger side, and we take care of about 60,000 patients across 4 sites, including a few school-based sites, which are above and beyond that. And so we're a good-sized organization, and we've been around for a long time, which is great. So let's jump in. Next slide. All right, so learning objectives today. Largely, this is a case study. My goal, with a reminder with this very large concrete block, is to be concrete. You've had a lot of the theory and a lot of the lessons, a lot of the best practices over the preceding sessions. My goal today is to show you one example of how an organization has taken those best practices into consideration and acted on them. And so hopefully lots of concrete examples today. I try to be very candid about what works and what doesn't work and challenges and how we overcome them and how we navigate things. So please feel free to chime in if you have like pragmatic questions about how did you fund this or how did this come to be or this or that. Please feel free to ask those. I have very few things I won't talk about. So here we go. So our two objectives, one is we will define our organizational approach to workforce wellness and what we at Thundermist mean by that. And the second goal will be to understand our plan for clinician wellness, particularly clinical leadership, efficiency of practice and community. And so we'll go through each of those domains with kind of concrete examples of what we're doing. Next slide. I'd love to tailor this to what you all want as much as possible, and also where you are in the journey on organizational wellness initiatives, because the degree of detail might be different depending on where you are. So I've got a few questions with our Slido here at the start. So if you want to pull out your phone and scan the code or otherwise sign in as Molly described, we're going to start with this question, which is, what is your role related to the National Health Service Corps? We'll get us a sense of what our organizations are, what our roles are in our organization.
So just a reminder that a poll should show up on the right side of the screen, or you can use the QR code and the URL to log into Slido and enter your answers there. See some coming in.
All right, looking at our sample size in the upper right-hand corner, I think that's what I see there. It's probably about, that's most of our attendees. So, okay, great. That is very helpful for me. Excellent. I am glad that you all are here. Site staff, middle management, and site staff C-suite, putting the time and attention into this is incredibly exciting. That's great. So, and then kind of seeing who else is not here is also good, just so I don't drone on about clinical things too much. That's great. Okay, wonderful. So we got folks who can make this change happen. And does your the next three questions are about kind of where your organization is in the journey of promoting clinician wellness, particularly as it regards to kind of those core domains that you learned about earlier in this series. So there's just three questions here. So if you can answer these, it'll give me a sense of kind of where each organization's at. So the first one is, like, your organization, oh, I got a box over it, so I can't actually read it. That's okay. What does your organization have an explicit plan for promoting clinician wellness?
Sorry about that. Let me try to figure out why there's a box there. Is it still showing up?
I still see the box, yeah.
Okay.
Yes, I do too.
Oh, box is
Is it
gone.
gone now?
There
Okay.
it goes. Thank you.
Nope, box is back. Box is gone. Box is back. Okay, great. So we got our 6 respondents. So no, or not sure. Very good. Next question. Does your organization have a designated leader whose job task is to promote clinician well-being, such as the chief wellness officer, director of wellness, etc.? Okay, so no on that. And then the next question. Does your organization regularly monitor clinician wellness with a standardized assessment tool? and no. Okay, great. That was very helpful. Thank you all for answering. So I would summarize by saying that we have a group here today that is clearly motivated to learn and do with regards to clinician wellness, because you're here and investing the time and thinking about it, which is very exciting. But when we reflect upon where we are in our organizations, we're all somewhat early on the journey in terms of making it happen. So that's great. Here we go. Let's make it start. So let's do the next slide. Oh, I missed a question here. Okay, this is good. So one last question before we go on. How much influence do you feel you have over how your organization promotes clinician wellness? Okay, great. So we're here, we're motivated, we're early in the journey, and most of us feel a moderate amount of influence that we can exert to promote clinician wellness, which is very exciting. Now we'll go on to the next slide. So an organizational approach, as you've gone through this series, you have probably heard this over and over based on what I've seen of the prior presentations. I generally think of it like this. There's kind of two models, roughly, of clinician wellness promotion. One is the physician or provider heal thyself model, focused on the individual resiliency of the person. Oh, there we go. The other model, or the other way to think about wellness, is creating a garden that is fertile ground for clinicians to thrive. And the latter of those two, kind of creating the garden where no matter what clinician you put in there, it's fertile and tended and they should grow and flourish, is what we consider the organizational approach. Where we really focus on creating that garden, creating that space where our clinicians can work that helps them flourish in terms of their wellness. It's not to say that, of course, like self-care and things to improve one's individual resilience are not important. But from an organizational perspective, there's two pieces. One is we have often much more impact or much more ability to impact the garden to how the environment is. And then two, in the studies surrounding this, generally the effect size, so how much effect on burnout can be created consistently is bigger when you focus on the organization. Individual resiliency things matter, and there's usually a positive effect for those studies, or a lot of them, but it tends to be a smaller effect size. So really focus on the organization with Thundermist. Next slide. So here we go. I want to say before this, we're going to go through lots of stuff that we do. From the outside looking in, it will look very crisp and clean, and it is very crisp and clean, and we're proud of what we do. Don't think that you have to do all of this to make progress. I would say that. And then also, like, we're not perfect. And so we welcome like comment on things that might be missing or question, and just reflect that this is a journey and not kind of a destination. So an organizational approach. So here's what we have done in terms of our organizational approach at Thundermist. So the first and a key element is making wellness a priority at your organization. And it is very non-glamorous to talk about strategic plan and annual goals, but they are very important. And most organizations function in such a way that if it's not in the plan or not in the goals, and it's just kind of a thing floating out there that we know we should or want to do, it tends to not happen. And so it's essential to add clinician wellness to the strategic plan and annual goals. Thundermist did this before my time, actually. I've been at Thundermist about 3 years. And it started from our senior leadership, or C-suite leadership, which reflected both from a moral and a financial reasons that clinician turnover and clinician well-being were a strategic priority for the organization. And so it's been in our strategic plan annual goals for over 5 years, and that's provided the kind of ongoing encouragement for it, as well as it kind of stands behind funding as we contribute funding to the cause. The next thing in terms of making a priority that's important to do, at least once when you're making the pitch or starting the program, is to financially model what kind of return you may expect by investing in clinician wellness and reducing burnout. And you may have had this link before, but there's a bunch of ways to do this. There's good studies saying that it's about $500,000 per provider per year. This link that's shared in the chat is the AMA's free tool for calculating this. And so here we put in our calculations. We have about 120 providers, our most recent burnout rate, percent turnover and amount per year. And you can calculate roughly like how much cost per year is due to provider turnover secondary to burnout. And you will almost always get a very big number, particularly when you consider some of the relatively small investments required for a lot of these interventions. So to think about how to compel getting it in the strategic plan, annual goals, and how to sustain that motivation, our financial modeling is really helpful for that. Once it's in the plan, once it's part of the strategy, and you have a financial model, what we did next and what I'd encourage is hiring a leader. And so here I am, ta-da! I exist at Thundermist because of the strategic planning and modeling that happened before my time. And they said, great, we need a leader to do this. Someone close to the C-suite who can make things happen and who has funded time to do this. And so I'm 50-50. I'm 50% clinical and 50% leadership regarding our clinician wellness. People will often ask, how do you do that financially? Because nobody's giving us money for the 50% of my time that I'm doing leadership. And I just said that the way that we model that generally for our clinical leaders is that the clinical time is sufficient to pay for the leader. Meaning that if I was working full-time, 100% clinical, if you looked at just my profit and loss for me individually, I would have a net positive effect on our overall health center budget and allow things to be allocated for other aspects of the health center budget. When you cut down my time, I still produce enough revenue for the health center to pay for me and my benefits and my care team, et cetera. Those kind of immediate costs related to my employment. And so we kind of lose some revenue, if you will, because I'm not 100% clinical, but it's effectively cost neutral and individual profit loss perspective. I would say that our organization's willingness to consider individual profit and loss neutrality as a sustainable solution, and I think it is for some things, including like leadership on this, is again, not very glamorous, but important commitment organizationally to making this happen. Next slide. So at Thundermist, as in many places, if you can't measure it, it didn't happen or it's not happening. And we really, both in our wellness work, but across the organization, are a very data-centric organization. We really work to let the data lead us on our clinician wellness work. So the way we've done that, and I know you've had a lecture, a couple of them actually, a couple seminars on different ways to do this. The one that we've chosen is to partner with the American Medical Association to do what they call their organizational biopsy, which utilizes a couple different things. For the burnout assessment, it's a Mini-Z 2.0 burnout survey, which is a 10-question burnout instrument with nice validation, particularly in healthcare settings. And then we also include questions which they provide, in their question bank regarding efficiency of practice, teamwork, community and belonging. And one really nice part about that of actually making it happen is that, one, it's free, which is really nice. Two, they are very collaborative in making it happen and give you a lot of support to make it happen. Three, it's pretty much out of the box. Like you call them up or you email them, and you're like, hey, I want to do this. They're like, great, here's the questions you can have. Which ones do you want? Boom, turn on the online link and it's done. So it's very easy. And then four, they provide a technology platform that allows you to overcome some of the difficulties in assessing wellness. So it's important to have some degree of confidentiality or anonymity in surveying this in order to get both accurate responses and respect people's sensitivity around this. And they collect the results for you. They actually house the data. So you can't even peek at certain things if you want to. You can never see like what Dr. Jones here at Thundermist answered because I don't even have the data. I could never drill down. And that allows them to blind things like groups less than 5. So you can never kind of de-anonymize the data. So I have no particular interest in, or no like vested interest here. So there's no conflict of interest, but we have found it very, very helpful to practice with someone who can do this in a low input, high quality way. And this, what it is, we've done an annual assessment. So we built out our own customized annual wellness assessment. We've performed it annually for the last 3 years. We've prioritized it to be anonymous, which it is. And then one thing we've done, which I wanted to pass on, is really important, I think, is that we've built in time for our clinicians to complete the survey. It's very ironic, of course, if you create a wellness survey and then you send it out and you say, great, so on your free time, when you don't have any time to do it, please complete this wellness survey. The hypocrisy there makes me cringe. It is generally how, like, in the world we do things. So we have recognized the hypocrisy that can come with that and built in time to complete the survey. And so we do that during our structured staff meetings. We start the staff meeting, we put the survey link, we stop for 15 minutes, everybody can go and do it, and then you come back. It's not that fancy, but it's really important, I think, both for respecting the wellness of our clinicians who are completing the wellness assessment, and then also for getting responses. As you know, if you just email out or just ask people to do something, you're going to get very low response rates, which makes the data quite faulty. By giving time, we get a phenomenal response rate, 90% response rate in our most recent year, which makes the data really reliable, which we enjoy. So with the data, it's important to share the results. If they go into a box and nobody knows what happens with them, it engenders a lot of distrust, or can. And so the way we share the results is first we share it with our clinicians, and we do that as a summary slide deck that we send to them by email. Then we also I go to each of the different departments and individually present their results, which gives a chance for discussion about the results and kind of the plan for them. They're also presented to leaders, so kind of our middle management leaders, and then to the C-suite with the space for discussion after. And that's always really important. The C-suite always has interesting questions and insights, and having that is really important for them to know our progress as well. Then using the results. You'll see here how we kind of follow the data and let the data lead us, but it's important to not only just survey once a year, but to use those results for action. Next slide. So the next part of letting the data lead you is to think about having EMR use data. As you know, like EMR use in pajama time and work after clinic or work outside of work are big primary drivers of clinician burnout. We can't do this, actually. We've tried. We work on ECW, and they do not have the ability to create EMR use data based on what's in the system. So we can't do this. But I wanted to put it here because if you are on Epic and perhaps on other platforms, there are ways that you can get EMR use data that can help you target and see the effect of your interventions. And so linked here is a paper that describes a few of the standardized measures for this, including this work after work per 8-hour measurement, the WOW8 measurement, which you see in the first line. And then below is a graph of what you can get out of the signal with Epic, which is a accessory reporting package out of Epic that lets you see, like, for this particular clinician, it's one clinician, you look throughout a clinical day and you can see like when this clinician's in their notes or their in basket or their clinical review or orders, and see throughout the day here in the morning before work, at work, and then at night as well, terrifying, when they're using it. So depending on what EHR you are, think about whether or not this is something you can get your hands on. And if it is, I'd encourage you to do so. It can be really powerful in terms of targeting interventions and seeing outcome. Next slide. So the next part of letting the data lead you is to say that oftentimes the other data that we get is the squeaky wheel. And this is my very low def graphic for the squeaky wheel. There's a chair and a squeak and a yellow box or a yellow exclamation thing. Don't do that. If we only listen to the squeaky wheels, we get a very biased and often not that impactful sample of what bothers people. So different sources will call these different things, but pebbles in the shoe is like one model from Mayo Clinic. Just like these ideas, these little things that get in your shoe and drive you nuts because they're there. They don't make you fall down. You can still keep walking, but boy, every day that pebble in the shoe will just grind on you. Or the AMA uses this getting rid of the stupid stuff or gross module to talk about things that just don't make a lot of sense and just grind you down, still get administrative or process inefficiencies. So one place to let the data lead you is in prioritizing and identifying these pebbles in the shoe. The way that we do it is first we crowdsource from our clinical leaders. Then we, as part of our annual assessment, ask all of our staff to prioritize those items and give an open-ended one to further crowdsource other pebbles that people might be experiencing. Next slide. So in the slide after this, I am going to show you which ones we identified and how we asked the question to prioritize. But I'm curious to know, from your perspective, what are some of the top pebbles in the shoe at your organization? So within your clinical space, what are the things that are just a nuisance or grinding, or you think are really wearing people down little by little, that are just silly, that are still there? This is a free text response. Feel free to type in anything you want. I think it'll pop up here. We can't see who says what, so fire away. Great. That's why one participant typing took a while, because you had a list of a few, as you ought to. So you're doing this, you know the issues. Great. So what we have here from our first person is pebbles in the shoe at this organization includes scheduling, amount of time for visits, grace periods for patients who are late, walk-in patients, and providers practicing differently. Excellent. So these are some, and lack of standardization. Okay, great. So these, I would say, are important, are probably more like large boulders with tacks on them in your shoe, and are part of kind of an overall analysis of like which efficiency or practice things, add-ons, yeah, like patient add-ons. So like things that really affect daily practice. Oftentimes pebbles in the shoe are smaller, simpler stuff. Like I have to log in every time I go to a new exam room, which takes me 34 seconds every time, which means I'm logging in for 32 minutes a day. So pebbles in the shoe is often used to identify kind of smaller, nuisancey type things that just add up over time. But having a way to, often in creating a strategic plan surrounding this, these type of things, big inefficiency and pain point drivers are things that are hopefully going to fall into the larger clinical plan. By the way, we have all of these, or have had all of these. Yes, these are all very common things. Next slide, Molly. So we came up with the pebbles in the shoe, the smaller things, not those big ones that you mentioned, but a couple smaller things. So this is the question we asked in our annual survey this year to help them prioritize, and they would prioritize how burdensome it is, based from extremely burdensome to not burdensome at all. And they're smaller things. So for example, your computer screen size being too small. We recognize that some of our machines are older and have these smaller computer screens, and some people complain, but not everybody. Like how much does this really bother people? Other examples would be like completing some transportation forms that we have to do all the time. HR related processes like requesting or obtaining reimbursement for continuing medical education, getting automated messages through our instant messaging software when our urgent care or convenient care is full. So it's kind of a bunch of little things that are just nuisances. And basically our medical director said, these are the things that kind of overall we find are either unnecessary or annoying or inefficient. And this, by asking the staff, allowed us to prioritize. Because I have my own priorities here, but it turns out that most everybody was most annoyed by having to complete these MTM transportation forms. They apparently hate them. And so it allowed us like, wow, that's a relatively low-hanging fruit, and allowed us to target that. So asking about the pebbles in the shoe helps. You'll also find that those bigger topics that you asked before, we get those very clearly in the organizational biopsy. The last question of the mini-Z is an open-ended question that says, don't quote me on this, but roughly, tell me about your work stressors and what we can do to address them. And that's where we get those kind of things that you mentioned: late patient policy, scheduling, visit duration, empanelment, etc. Next slide. So next in the organizational approach is just understanding which things you already do well, and if not, which things are kind of requisite for a starting place. This is a reflection on when I started, kind of we understand what we did well to start with. And I wanted to reflect on them because they're not part of our plan that we'll share later because we were already doing them. But I do think that they're very important overall big picture for an organization to have in place. So the first one is job crafting. There's some research out there that says that if less than 20% of your job is doing something that you feel passionate about, you're much more likely to burn out or switch jobs, which makes sense. And so job crafting, we consider the default being that people have a job that mixes up job tasks in some way. And so surely many of our clinicians are just full-time, seeing patients 40 hours a week. That's what they do and that's what they want. But many people want some mix in there. And so things that we include in that include resident teaching, hospital medicine, inpatient OB care, teaching at the medical school, or some people an external specialty practice. For example, we have a clinician who also works at the gender clinic at the local children's hospital. And so it's worth intentionally calling this out in your organization, like, is this something we do or don't do? If it's always like an exception that's, oh yeah, we can work this out for this person, but we don't usually do this, or like most of these are ultimately kind of somewhat of a money losing thing. We do them in a cost neutral way, but like you don't earn as much money as an organization if a clinician's doing some of these things as compared to just seeing patients all the time. So thinking about how you financially model this is also important. So job crafting is really important. Second one is schedule control. We're large, relatively speaking, with over 120 clinicians, which gives us a lot more flexibility perhaps than a very small clinical clinic. But we really value, prioritize, and encourage flexible schedules that meet people's life needs. That includes part-time clinicians, extended days, condensed weeks, and flexible scheduling. They may vary from week to week depending on people's other commitments. The other one is salaried clinicians. And I think this is less of a uniqueness in the FQHC world, but in a truly like productivity-based, RVU-based system, it is an incredibly powerful disincentive for all the things that that encourage wellness. And so having truly salaried clinicians and benchmarking that in experience and being transparent about how we pick salary marks and equitable among staff is something we value. We always say that if the whole list of what every provider in the organization was paid was accidentally emailed out to the whole health center tomorrow, it would not be good. It's kind of private, but like we also wouldn't have like a big uprising among our clinical staff. I think people would look at their salary and they'd say, oh yeah, that makes sense. Like that's just where I should be. And we think that that degree of equity and transparency is important. Next slide. A key piece is leadership, as we'll talk about in our plan. We're lucky in that even before my time, for almost 10 years now, we've had this Leadership Development Institute. And I just want to say a brief word about it, because leader training is important. So this is a program that we have that's mandatory for all new leaders, both like clinical leaders as well as others. Occurs on paid time, so it's not in addition to, but part of your core job tasks. And we do it once a year for everybody who's been a new leader within the last year. And we partner with University of Rhode Island, one of our local universities, for expertise on this. And we use the for your information model. So it's like one of these established business management models for this program. Sorry, I saw a comment, sorry. Come back to the comment. I do see that comment. And it's been really important. And it's been really useful. It's got room to improve. As I said, all these things have room to improve. We're actually currently doing it in a more equity and trauma-informed manner to better reflect our institutional values rather than a traditional kind of hierarchical leadership model. So we're currently revisiting it in that context, but having some kind of plan for how to get all leaders up to a certain institutional standard is important, whether that's done internally with a partner or outsourced. I'm going to go to the chat here. I just saw that question pop up. So the question is about with these job mixes. Yes, so with these job mixes, particularly in the context of National Health Service Corps, what counts as clinical time and what does not? It is somewhat complicated. I see the link there. And we often have this as part of the conversation for these job mixing arrangements. And there are certain exceptions, and it depends on like which patient population they're serving. So an example might be just thinking about like teaching. So like if one of our clinicians goes to an off-site residency site and teaches there, that does not count as clinical time by my understanding. But we do house a residency on site, which takes care of Thundermist patients. And so if you're teaching in that capacity, it can count as clinical time up to a certain number of hours. That's my layperson understanding. Don't quote me on that here. But there's ways to kind of think about it, and it's important to have that collaborative relationship with HR and then your National Health Service Corps, like regional representative, to ask some of those questions as you're sussing this out. It's pretty, yeah, because even the language in the very long and prescriptive National Health Service Corps manual there's room for interpretation there, right? And so it's important to work those elements out. Molly, the slides came down.
Yes, I'm so sorry. My power went out just now. We had storms in the area, but I did just connect to my hotspot. So let me pull the slides back up. I'm so sorry.
There you go. That's a wonderful coincidence, right?
Yes, I know.
Everything's okay with the power out.
Sorry about that, everybody.
That's okay. So the next slide that I was going to pull up was, oh, this one. That was fast. I'm impressed. So this is about
Let me get through the slides.
Destigmatizing mental health treatment. It's also something we felt like we did quite well. So as you probably know, one of the HRSA requirements is that you define how and when you assess fitness for duty, but it's quite different to the health center on how frequent and in what way you do that. This is also done in like state licensing, and what we know is that depending on how that's asked, and particularly how it's asked traditionally by many state licensing boards and hospitals and clinics, leads to avoidance of mental health treatment by healthcare professionals. And so in particular, when questions ask about, for example, have you ever been treated for a mental health condition without context for like, that you often say like that may cause difficulty with your job. Of course, like that if you know that question's coming and you're starting to feel depressed, you very well might avoid that mental health treatment because you know that then you have to disclose it on your thing, and then your employer will know and ask questions about it, etc. There's been studies to look at kind of avoidance of mental health treatment, and people do avoid it historically if these questions ask about past treatment that's closed and done and not affecting current fitness for duty. So let's look at the next slide. So here are some concrete examples of what these questions might look like. And I encourage you at your organization, simple thing, but take a look at what this question is at your organization. So the first one, these are all from real places that I've applied for privileges. The first one is the health status question. So do you have a physical or mental disability which impaired, past tense, impairs or could impair your ability to carry out your professional obligations? So for this one is a bad, don't do that. This is the old school question of what you should not have, but many places still have, and this is still the question at this hospital. And this is not the question to ask because it asks about like past things that are really not relevant to current fitness for duty. Particularly could impair your ability to carry out your professional applications. Like, that is very broad, particularly as it relates to mental health. It's like, well, I have depression. Could it impair my ability? Like, sure. I mean, like depression could get really bad and impair your ability. And so like hypothetical, could this happen, are really stigmatizing and drive people away from treatment. So the first one's an example of a poorly worded question to avoid. Second one is the second example. So this question was, different hospital I applied to. Do you presently have a physical or mental health condition, including alcohol or substance dependence, that affects or is likely to affect your ability to perform professional or medical staff duties appropriately? So this one's better. We're getting there. So at this one, at least is not asking about the past. It's asking about presently. Do you have a physical or mental health condition, including alcohol or substance dependence? So affects, but it still acts as or is likely to affect your ability to perform professional or medical staff duties. So it still provides like a conjecture, like, I know it doesn't yet, but could it? It also explicitly asks about mental health and about alcohol and substance dependence. And there's no like regulation saying you have to ask about those. So again, have people read this and know about it and think about what's on their next application. It may still drive people a little bit away from treatment for those conditions. And then the last one, different example is, if the following, question, are you able to perform the duties of the job in a safe, secure, productive, and effective manner? That's it. Doesn't talk about mental health, doesn't talk about past, doesn't talk about, well, maybe could something you have make things worse. It just says, can you do this job? Are you fit for duty? This is the one that our organization asks, this last one here. And it's the one that both meets the compliance requirements for HRSA, but also is really destigmatizing in terms of pursuit of mental health treatment. Next slide. There we go. We put that on in case someone reviews the slide like after. I don't want them thinking that the first one's the good example. So the last one is a good example that meets the regulatory requirements and asks about fitness for duty. Next slide. I'm going to pause there. So that is, actually, that's true. The last part is make a plan. Make a plan. So you've gone through the different pieces. You have made it a priority. You've started to gather some data. You've assessed where you are currently. And then you got to make a plan. I'm a big plan person. You know, if you make a plan for it, it will likely happen. If it's kind of willy-nilly, makes me nervous. So we made a plan. So our Thundermist plan is the Thunder plan for clinician wellness. Some lightning bolts for the thunder and lightning that comes with that. Thundermist is a great name for lots of reasons. Thunder everything exists here, but Thunder plan is what we have. So the Thunder plan for clinician wellness, and we made 3 parts to that: clinical, leadership, efficiency, or practice, and community. So I'm going to pause there. Now I am going to pause because the next segment of our grand rounds today will be about going through each one of these sections and thinking about how we approach it. But before I do that, I just want to pause for any questions before that about our organizational approach or about some of those things we just talked about. And feel free to raise your hand. I think we can see those. Type it in the chat, however's easiest for you to ask while it's on your mind.
There was a question in the chat previously, basically asking, since NHSC participants have to be working full-time clinically, could they be an administrative, like clinician wellness type role if it was half of their job? Looking at the guidance for NHSC participants, it does look like 36 hours out of those 40 per week do have to be spent on patient care. And I did want to ask Diane if she wanted to chime in with any additional info, or if anyone else here has a response.
Yeah, I answered that question, I think, while you were trying to answer the question a little bit, I think, while your power was out.
Sorry.
Saying that, yeah, it's important to attend to that. And it's something that we work through when we're job crafting for clinicians. And there's a bunch of different ways that 36 can be made up. And so to think intentionally about looking at the document for how to piece that together, but I'd also welcome any insight that Diane may have, of course.
I like the Thundermist plan, Thunder plan for clinician wellness. I've seen that before. I do think that from our perspective, our clinicians really have to have some advocacy to start it if it's not there. And that might be a different kind of response to your question, but I think it is valuable, and we have supportive regional operations and site and representatives who will be able to assist in that in some small ways to help with the site to create this environment. So it may not answer the question completely, but I do think there is supportive measures that NHSC has in place through their site representatives.
Great, thank you. Yeah, and I'd say that like we work with our, I don't know the right term, but the liaison or site representative or the connection that we have with HRSA and National
Yes.
or often for some of these very nitty-gritty questions of, okay, I want to hire Dr. Malek, but he wants to be full-time National Health Service Corps. He has this commitment, like, well, how much can be this and that? And like some of it's hospital and some of it's this and it's this hospital, like what counts? And I just encourage everybody to collaborate with your National Health Service Corps.
You just got to ask the question. Got to ask the question.
Yeah.
And we can give you some information. And I encourage everyone on the line to make sure that you are asking those questions of your site representatives, potentially in our field.
Great, thank you. Any other questions before we forge ahead? Okay, off we go. Everybody take a deep breath. We're about an hour in, which means everybody's attention has probably waned. Take a breath, look away. Look out a window if you have one. Stop for a second. Take a breath. And come back, and we're going to do this again for another hour, maybe. Great. So we're going to go through clinical leadership, efficiency, or practice in community and talk about what, again, concretely we do to approach that. So clinical leadership, why? You're probably familiar with this concept, but here's a study out of the Mayo Clinic looking at the importance of clinical leadership or the immediate clinical supervisor of providers as it relates to burnout and job satisfaction. What this study did was ask the clinicians, the practicing providers, what their clinical leader does or how much their clinical leader does certain leadership tasks. And so things they asked about include, for example, holding career development conversations, inspiring me to do my best, is interested in my opinion, encourages employees to suggest ideas for improvement, provides helpful feedback and coaching on my performance, recognizes me for a job well done, keeps me informed about changes taking place, encourages me to develop my talent and skills. even just reading that, I'm like, oh yeah, I want my clinical supervisor to do those things. Like those sound good. And what they found in the study, which is not surprisingly, the more the clinical leader did that, the more they were doing it, the lower the prevalence of burnout and the higher the rate of satisfaction, job satisfaction, in a very statistically significant way. And so this is one of the studies that I think tells us what we all know, which is that effective clinical leadership addressing the different domains of clinician wellness does have an impact on burnout and satisfaction. We also know from not just this, but broadly, there's a couple other things that are true, is that many people leave their job not because of dissatisfaction with their job, but because of dissatisfaction with their boss. And that is true in medicine as well. So this is why we focus on clinical leadership, because there's good evidence it really matters, and it does. So next slide. So how do we translate that reality into practice? So we used the Mayo Leadership Index, which is essentially those questions from that research study. Oh, we can go back one. Thanks. And so the Mayo Leadership Index is those questions about those key leadership qualities. What it is the bottom-up instrument where we surveyed all of our practicing clinicians to ask them about how their clinical leader, how their supervisor, how their direct clinical supervisor performed or was performing on all these different elements of clinical leadership. As with the other things, we gave them scheduled time to complete it during our department meetings. And then it's important to repeat it after you do some intervention there. So yes, so we asked our staff, how are their bosses doing? So next slide. So how would here's a Slido for us all. How would your leadership respond if you asked to do a bottom-up clinical leadership assessment? Eagerly accept, be hesitant but approve, consider but ultimately decline, or quickly refuse. And I think all of these are very possible within any organization. We probably fell in the be hesitant but approve, carefully proceed. Think about intentionally how we're going to do it, because there's a lot of nervousness about what harm could be done. So we're 50-50. 50% say, everybody can say, okay, everybody gets pause, and half of them approve and half ultimately decline. Yeah, it's an important thing to navigate. A couple pieces, making it part of a bigger plan helps. Talking about the reason for it helps. And then as we'll see in the next slide, like thinking about how you're gonna share, disseminate, and use those results is really important for easing some of the concerns that people often have when they first hear about, wait, staff are gonna review their bosses and we're gonna then like fire their bosses because their staff don't like them. You got to go talk through that for your process and get to an acceptance phase. So let's go to the next slide. So we do this Mayo Leadership Index, the bottom-up survey. And then we, before doing it, of course, made very clear how we were and weren't going to use the results. This was not punitive. It's not going to get people in trouble. It's not going to get them fired. It's not get them on performance improvement plans. This was to inform individual improvement and kind of a reality check for our clinical leaders to partner with their supervisor on collaboration. And then also think about like what organizationally is reflected in the results. So to do that, we have our structure is like a CMO, a chief medical officer, and then the clinical leaders all reporting to that person. And so in our setting, that person individually addressed these results, and the results were not shared with other people. So people weren't seeing, oh, I'm doing, my staff think I'm doing this well, but so-and-so staff thinks they're doing terribly. Like, we didn't allow for competitive critique. We just used it kind of privately to inform reflection and improvement. More importantly, I think, is that we looked at the data as a system to think about what organizationally is contributing to these different performances. And what we found, we said, oh, that's interesting. Like a couple of our leaders are performing like way below the others. look at that. They're all at the same location. Oh, that's funny. Like, oh, look at that. All of them have 20 plus clinicians reporting to them, but our other sites have only 10 clinicians reporting to them. When we talk to those leaders, like, that's funny. Why do you think this could be? And they're, I have no time to do it. And so it was really useful data for us to see that as we'd grown and ratios had changed, we hadn't really grown our leadership at one of our sites in particular to meet the growth in the clinical staff. And as a result, we had a real imbalance. It was kind of this left-hand graph here where each leader was supervising a really unmanageable number of clinicians. And so we right-sized it. We hired 2 new medical directors, which is our associate medical directors, which are like site level direct clinical leaders, to right size it so that each clinical leader had an appropriate number of supervisees that they could actually have time to meaningfully supervise and provide mentorship for. Next slide. So that's been our journey so far in clinical leadership. We're just repeating the survey now. I'm excited to see where we go from this iteration on. It's a continued journey. So next will be efficiency of practice. So let's jump to that next slide. So you've been part of the series, you know why efficiency of practice is important. But burnout broadly is electronic health record plus a complex system plus the pandemic happened. Yeah, that happened. Leads to work-life interference, which leads to burnout. And so efficiency of practice means that things fit into the time they're designated for, which prevents that work-life interference, improves a sense of empowerment and ability to do one's job. So I don't have to tell you why efficiency of practice is important, but so let's go on to the next slide. So we spent a lot of time in this domain recognizing how important it is. And so we're going to go through a bunch of items here. Again, these are not like the be all end all, but I hope that they're examples of things that you could consider or that you can see like, oh, this other organization has found them helpful. So the first one is the EHR. The #1 free text response in our annual wellness survey every year is get a new EMR. We have looked at that. For a variety of reasons, it's not going to happen. Also, interestingly, the data on it is that from a wellness perspective, switching EHRs and like which EHR you have in particular is not all that predictive of how much you dislike your EHR. It tends to be about how we use it. And within an individual EHR, some users are very efficient and some are very inefficient for the same system. So we have focused on usability. We do that kind of formally in a usability committee that we have that meets monthly of different clinical end users that helps guide some of these efficiency and usability goals. And here's some of the things we've done. So one is training. So it was recognized that our initial training was not great. And after that, there's nothing else. Like all the like higher level efficiency tips and tricks, like there was not really anything for it. And so over the last 1.5 years, we've built out our initial training a lot and then created a part 2 training that allows for our clinical staff to learn those little tips and tricks that make EHR use much more efficient. Next is click reduction. So one thing we did was we customized or allowed staff to customize the sensitivity of their medication safety alerts. There are good studies showing that lots of medication safety alerts just cause alert fatigue and people just click through them. And so the default out of the box setting and our historical out of the setting was that like moderate interactions would get a pop-up alert in the EHR saying interaction, review all these possible interactions, click OK. And people were getting hundreds of pop-up alerts every day telling them about possible medication interactions. And so we empowered our clinicians to adjust that setting themselves. A few people said, nope, I really like it. I want to know every time there's a chance of an interaction. And most people said, I'm going to turn that sensitivity down a little bit and only get the major interactions or perhaps get none. And of course, went through risk and our pharmacy department to kind of get buy-in and assess the risk and benefit of this. But doing that allowed us to decrease the number of pop-ups or med interactions dramatically for our clinical staff. The second one is just integrating different data systems into your EHR. Here's one example in that in Rhode Island, as in many states, there's a prescription drug monitoring program, which is the state database that reports where all controlled substance prescriptions are reported in, and clinicians are legally required to check it at certain times, for example, before the first prescription of an opioid analgesic. And you also have to check it at certain intervals. It used to be you have to go to a separate website, type in the patient information, search, then it was recorded, and maybe copy and paste it into the EHR, like this whole workaround process. And we worked with the PDMP vendor in Rhode Island to integrate that into the EHR. And so now you can just click on the little button and it shows you right there for your patient their PDMP results. And also documents that it was checked, so you don't have to do that. And we set the alert to like remind you every 90 days, which is the legal requirement in Rhode Island, to check it if you haven't already within 90 days. And so we took that onus off the provider of kind of remembering when you last checked it. So a little usability thing, but taking away a good number of clicks every day and decreasing some of the cognitive burden for clinicians. Next slide. In all of our states, there's probably some health information exchange or other external data you might be able to get. Here's just one example of something we worked on, and that is getting pharmacy fill data, I believe through SureScripts, don't quote me on that, about when and what medications patients have actually had filled at the pharmacy. It's really powerful information in terms of knowing what medications patients are actually getting. And so we turned that on and made it work within our EHR so staff could have that data at their fingertips rather than calling the pharmacy and saying, hey, what med did they pick up last month? Was that their lisinopril 40 milligrams or lisinopril 20 milligrams? Now it's one click in the EHR and you can see which medication the patient picked up. Next page, next slide. Okay, so we're going to talk about medical scribes a little bit. First, I want to assess kind of where we're at in terms of our knowledge of these. So does your organization use medical scribes? Yes. In a limited fashion? Yes, commonly. Yes, required, or no? Okay, great. So mostly no, and one yes in a limited fashion. Excellent. So let's skip on to the next slide. So medical scribes. First, why medical scribes? One, there's good data to show they're a really large effect size, perhaps the largest single intervention effect size you can get for reducing clinician time after work. The best EHR, the best user, is still pretty inefficient a lot of the time. And so scribes are really a workaround for inefficient EHRs. The reference at the bottom is one of those more recent studies about scribes and the benefit that they have for clinician wellness. So scribes. So we've been on a scribe journey for a long time now, actually, about a long time, 5 years or so. We did the traditional in-person scribe first, which is like where the physical person who's a medical scribe follows you around all day and sits in the room with you and sits in their computer and types everything out. That was challenging for a lot of reasons. The biggest one in our setting being retention, turnover, and scribes availability. Even though we're in a pretty large urban area, like there just weren't that many scribes available. And so it was a pretty limited hiring pool and it became hard to replace scribes if or when they left. So kind of sustaining that workforce was challenging. Next, we moved to the team-based care document, the team-based care model, team care model, which are medical assistants that were then trained also as scribes, and there are 2 MA scribes with each provider. And we did this partnership with the Scribe Training Institute to make that happen. And that one we found to be very difficult for two reasons. One, it was more expensive, and two, it was a workforce. So there is this normal attrition that happens with any group of staff, and being able to retrain and replace a relatively small group of internally trained MA scribes is really prohibitive, really difficult. So that one didn't work great. So over the last 2+ years, we've been on the remote or virtual scribe one, which has been by far our most successful so far and very successful. So remote or virtual scribes, what they are, for those that are familiar, are real humans, though they're virtual, they're real humans sitting in a cubicle somewhere in the country, who is connected by a speaker to your computer. In our case, we use laptops. They use our speaker on your laptop and listen to you all day. They sit in their cubicle with a headset and listen to your day telephonically through like a secure internet connection. And using what they hear, they're able to be directly in your EHR and scribing into your EHR in real time to complete the notes and documentation on behalf of the provider. They've been really beneficial for a bunch of reasons compared to the other models. One, I would say, is that from a scalability perspective, because it's a national service, like it's remote, like these scribes can be anywhere. And so it allows the scribe vendor, the person that hires the scribes, to really spread broadly, which has eliminated the workforce shortage issues related to scribes. So that's great. Second, it is ultimately less expensive than even the other two options, at least in our situation, which is nice and makes it more sustainable. And then our providers have actually liked it more. They find that having the speaker in the room doesn't really disrupt the physician-patient relationship in a meaningful way. In fact, they find the relationship to be better because they don't have to be staring at their computer all the time, and they can actually make eye contact and communicate. And so kind of avoiding the person in the room, the real other human in the room, has been nice. So we've loved our remote and virtual scribes. Funding. We keep the program essentially cost neutral, and we do that by requiring that each provider who decides to use the scribe add 1 visit slot for every 4 hours of scribe they have. And the revenue created by 1 visit per 4 hours of scribe essentially pays for that scribe for that clinician. Next slide. So kind of to the follow the data piece from earlier on, here's just a little look at our 1-year evaluation, some of our 1-year evaluation of our scribe program, which is a little dated now. We're just doing our year 2 evaluation. But we did a focus group, and then we also looked at our annual wellness survey by people with and without a scribe. And what we found was that from the focus group, there were 3 big themes. One was a really large positive effect on job satisfaction and perceived well-being among those using a scribe. Second was perceived documentation time is markedly improved, as we had hoped. And last, an ability to focus on the patient is better. And we saw those come through really clearly in our setting. And then we looked at some of the data from our annual wellness survey for people with scribes and without scribes. We saw benefit in essentially all the domains we looked at. The first one's a graph about job stress and the percent of people reporting excessive job stress. And you can see the red bar up on the left is the scribe, and the blue is no scribe. You can see the red bar is lower, though it's still pretty high. People still have a lot of job stress. It's substantially lower than the no scribe. For job satisfaction, people with high job satisfaction, you see the red scribe is higher than the no scribe. And then there's a question in the mini-Z about excessive EHR work at home after hours. And you can see here that percent of respondents reporting excessive EHR at home is much lower for the scribe than with no scribe. So some of our early results really promising, seems to be continuing, and we're really excited about our scribe program. It's been a big success. Next slide. Ooh, here we go. Okay, so next we're going to jump into some of the other things that really burn folks out. But I'm curious to know, and this is kind of a poll of some common items, from your perspective at your organization, which clinical administrative task is the most burnout inducing for your clinicians? lots of things drive administrative things, can burn one out. But what do you think is the most? Inbox. Oh yeah, there's a winner. First one, quick to inbox. Great choice. Two for inbox. All right, we got a couple for inbox. Three for inbox. Everybody, yeah, inboxes. It's the topic du jour. I just had a wellness conference and everybody's talking about the inbox for good reason. More inbox. I love it. I love the consistency. Okay. So we're going to go on and talk about how we address kind of a variety of these different things, including inbox to a certain degree. So next slide. So lessening the crushing administrative burden, doing all those administrative tasks that a provider does not need to do. So briefly mention some of these because it sounds like they're not too bad at your organizations. So prior authorizations can be a huge drain and are in many places. So we have a large prior authorization team. Think about funding for that. And that comes back to the financial model at the beginning. The prior authorization costs money, but we also know the impact of not having it financially in terms of turnover, and it makes it a bit of an easier financial pill to swallow. Medication refills are a big piece of inbox management at many organizations and were the primary source of like inbox tasks at our organization until we implemented a pharmacy program to do medication refills. And so this one, funded by our 340B program, we now employ clinical pharmacists and many pharmacy technicians. And the pharmacy techs do the inbox medication refills for our clinicians. They do them according to like a standing order that we have and this big protocol for safety and consistency, et cetera. But that had took out about half of the inbox items because about half were refill requests. Forms can be quite draining for clinical staff. And so this is a process of a continuous improvement within your organization. One small example was to empower our RNs, our nurses, to complete these medical transportation forms. I mentioned another one. That was our leading item on our pebbles in the feet. We said, okay, like let's do it. So we figured out that providers don't have to do it. Nurses can actually sign it. They can do it online, et cetera. And so we reworked the process to empower our non-provider staff to complete that form as an example. Patient portal messages. With the growth of the patient portal and messaging directly, this has been a big part of inbox for many places as well. And I've talked to many colleagues where those just go to the provider. They just go straight there. I'm like, how is that possible? To me, this is mind-boggling. When someone calls the health center, they don't just send them to our extension. Like there's a whole triage algorithm and process of where that should go. And admittedly, like at our organization, when the portal first turned on and went wild, like they were mostly coming to the provider. And we've worked really hard to make it follow basically the same algorithm that phone calls coming in get. And so whether that's clinical triage by nursing staff or to a support team for a prior authorization or whatever it might be, now, much like phone calls, the vast majority of patient portal messages are touched and addressed by someone besides a provider before they get to the inbox. I'm going to pause there because I actually see the question from Jamie. So the question in the chat is there a reason that your organization chose the remote scribes over a dictation system like Dragon? Yes. They're very, very different actual services that you get in terms of what they're like. Dragon as dictation, of course, can't be done during the exam room, generally, and works very well, at least in REHR, for dictating into free text fields. Within eClinicalWorks, it doesn't allow voice commands from one section to the other, at least our version of eClinicalWorks. And so you can't navigate through a note. You also can't click boxes. You can't order things. You can't send referrals with it. So like it's good for dictating the plan, but beyond that, it has pretty limited functionality, and it has to be done outside of the exam room. So you finish your visit with Dragon, and then you still have to do most of the button clicking and dictate. So it kind of is, and we do have it, and some of our clinicians who don't have a scribe because they don't want to use it to dictate because they are very slow typists, and that's fine. But it still relies on the clinician to do most of the inputting. A scribe is like a totally different experience. With a remote scribe, during your visit in real time, your note is being created, including your plan and your assessments. And so there's not a creation of note when you get out of the room. Second, like scribes can do much more than just the writing. They can order tests, they can order labs, they can order imaging, they can pull in diagnoses, they can put in the billing, they can put in the follow-up, they can put in the exam, they can click the buttons for quality that you talk about verbally with the patient. And so they allow for a lot of additional EHR completion factors beyond what Dragon can do. And it's all done truly independent of the provider, except for what they're speaking during the exam or during the clinical encounter. All right, let's go on to the next slide. Okay, so cross coverage for paid time off. This is really about inbox as well. One of the places that inboxes become very burdensome is when my clinical teammate, like the doctor on my team that I share like a team with, is on vacation. Traditionally, like, someone has to do their, not traditionally, someone has to do their inbox while they're not there, right? And like we are very proud of how much clinic PTO of paid time off our clinicians get per year, and we want them to take that. We don't want them to feel bad about it. We don't want them to come back to lots of work after. But when your co-physician is off for 7 weeks a year, that means that 7 weeks a year I'm doing their inbox. I don't know their patients, which means that 7 weeks a year I'm working an extra 10 hours a week to like do all their inbox stuff for 8 hours a week or however many it might be. Wow, that takes like inbox volume from unsustainable to wildly unsustainable, and it's just work after work and creates all these things. Inbox coverage isn't as good, it's incomplete, people come back from vacation with stuff. It's like PCPs covering PCPs is a pretty no-win situation from an inbox management perspective. So we recognize that problem that came through loud and clear in some of our data collection. And so what we've designed is somewhat unique, so I want to tell you about it in a little bit of detail, is a cross-coverage clinician program. And so we started with small, 1 nurse practitioner, now up to 5 nurse practitioners. And what they do is that they each have a mix of clinical responsibility and time designated and paid for cross-coverage work. And so, for example, they might see 20 hours of patients a week and then have 20 hours of budgeted time blocked and protected for doing the coverage for people who are out on vacation. The way we modeled it, similar to the clinical leaders I was mentioning before, is that they each have just enough clinical time for each individual profit and loss for that particular provider to break even financially. So it becomes really a cost neutral way to do this. What we've seen as it's grown and as it's become more refined and better is that first it saves a lot of time. So PCPs, again, were covering their colleagues for 7 or so weeks a year, 5 to 10 hours a week. They were working, 40 to 80 hours of work per year outside of work. And that is gone because really the cross coverage clinicians are doing all of the cross coverage. And so we're saving our PCPs huge amounts of time, like huge amounts of time. The second benefit is better coverage leads to lots of downstream sequelae. It's good for patients because their issues get addressed in real time in a quality way. And it's really good for the person on vacation because when they come back with that really high quality coverage from someone who's expert at it, a cross coverage clinician, they're not having the huge stack of paperwork to catch up on. Like their things have really been done for them while they're gone and they can come back and jump right in. So it makes the after vacation pain much less. So it's been a real win, and I'm happy, of course, if anybody's interested in some of the more details on how that works, to share. Next slide. So then there's some predictable stressors. I heard this at a conference once, and someone was describing running a health center. It's like running a hurdle race. Like, there are these things that happen right? You need to like recertify your grant, you need to apply for FTCA. Like, there's these predictable stressors that happen each year in terms of running a health center. And it's the same for clinicians. There are predictable stressors, and thinking about what those are and addressing them is important. And you mentioned a couple of them actually in your Pebbles ideas. So some of the ones that I'm thinking back to are like the add-on visit, the walk-in patient, the late patient. Like, these are predictable stressors, right? Like, how do we manage these? And so thinking about those predictable stressors and how to address them is important. The ones that we have done a lot for include behavioral health crises. A behavioral health crisis will blow up a clinical day, but they happen, and predictably they happen. Not when they happen, but they're gonna happen. And so in our setting, like our integrated behavioral health program and real-time clinician access for warm handoffs has helped mediate that predictable stressor a lot. On-call volume is predictable. We will have to be available for our patients after hours. Versus says we have to for good reason. We have a huge health center, and though we break our call into 2 groups, when you're covering for 30,000 patients, you will get a lot of phone calls after hours. It is guaranteed. That is a predictable stressor. It was over 100 calls per week when you're on call after hours, which meant you didn't sleep much, which meant your weekend was all work, and it was very exhausting. So again, thinking about that financial model, we said, well, we want to do something about this. It's going to cost a little bit of money, but like, boy, we can hopefully reduce burnout and save some money on turnover. And so we invested in an after-hours nurse triage service, which is a third-party vendor. And so when a patient calls into the health center at night, just like during the day, they get connected to our third-party nurse triage service. What's the same as the day is they get connected to a nurse for triage, right? And the nurse can triage whether it needs to be addressed then, the next morning, whether they need to go to the ER, their appropriate level of care. And then only if there's a clinical question or a need that the nurse can't complete do they then pass that call on to the on-call provider. And with that, we saw the number of calls per week go from over 100 per week to less than 10, which is a huge wellness benefit for our clinical staff in terms of call. Last is social determinants of health. It can be very disempowering if your patients can't access what they need as you're trying to treat them. And so I think all of us are intimately familiar with that conundrum. And so I listed just a few things that we do, not necessarily for clinician wellness, but that really impact clinician wellness. So having an effective medication assistance program, like financial assistance program through 340B for medication access. We use Uber Health for transportation access in addition to some state resources. We have housing specialists to aid housing access, a community health team for like intensive community-based case management. So it's nice organizationally as you're making these plans to make sure that you include things you're already doing well or can work on, and frame those in the context of like, yeah, this is good for patients, of course. It's also good for our staff. Next slide. So this is our last slide in efficiency of practice. The last one is, here's a diagram of the Thundermist care team. It is massive. So of course you have the provider or clinician, the nurse, the medical assistant, the receptionist, the scribe, that core care team. And then we have this huge network of like social service and supportive service and additional service people that one would integrate with to like fully and efficiently care for your team. The tobacco treatment specialist, the pharmacy tech, the home visiting nurse practitioner, all these people to coordinate with. And we realized that people are really underutilizing this bigger care team, primarily because they never really got oriented on how to do it all. And so we spent a lot of time enhancing our orientation for onboarding and then some refreshers to help people more efficiently manage their care team and utilize their care team. And next slide. Okay, thank you. That was a lot. Whew. Efficiency of practice. Again, we spent a lot of time there. It's super important. And hopefully those concrete examples got your mind going about what at your organization might be doable or attainable. Next, last but not least, is community of the Thunder Plan for Clinician Wellness Community. Next slide. So again, follow the data, we measure it. I put in here are the questions that we ask with regards to community, two of the key ones. And then let me mention a few things we do here. So one is peer support, and I know you talked about this in the previous session. The way we do that, one of the ways we do that, I should say, is recognizing that particularly difficult cases routinely need peer support. And the first place we've worked on that is with our death notification procedure. How or when you hear about a death of a patient that you've known for a little while or a long time can be really challenging. And then if you're just alone and dealing with that, it can be even more challenging. So we revised our process in terms of how, when the provider is notified of a patient passing to make it more trauma informed. And then including in that the link to their clinical mentor, like a direct connection with their clinical mentor, and the recommendation, expectation that they can connect if that's the case, if they need support. Next slide. Then here's another follow-up data example for community. So again, these two questions we asked, what you see is the first question is I feel a sense of community with my colleagues, and the bars are the percent that agree or strongly agree. So 74% said, yep, except for in one of our sites, this says wound socket. One of our sites was substantially lower than everybody else at 67%. Also on the next question, I feel a sense of belonging with my work colleagues, lower 60% compared to 71% overall in the health center. And this was pretty consistent over a few measurement periods, and we go, what's going on here? And we used this to target that outlier site, that particular site that was having a lower degree of community and belonging. And what we've done is we've repurposed an existing meeting for what we think is more important, which is building community among this clinical site. And so we moved the meeting even during the pandemic to in person. We did some intentional team building and shared experience exercises. Tomorrow, actually, for this meeting, we are going on a walking tour of our community together. So things that bring us together to, again, increase that sense of community and belonging. Next slide. So that is the Thunder Plan for Clinician Wellness. We focus on clinical leadership, efficiency, or practice in community. I'm going to pause there before we go into a relatively brief case study on a way that we've used this to address a need in the health center. Any questions?
If anyone would like to verbally ask a question, you can raise your hand to unmute and we'll send you a request to unmute. Or you can just post something in the chat.
Ooh, love it, Elizabeth. Thank you. Sabbatical programs for providers. Do I have any experience? The question is, sorry, do you have any experience or opinions on sabbatical programs for providers? At the AFP Clinician Wellness Conference this year, there's a lovely seminar on these sabbatical programs and what their role is in medicine. My personal experience with them is that we did change at Thundermist. We don't have an explicit sabbatical program. We did, however, change our PTO policy to allow for them to occur should the clinician want to. And they're a little bit them, meaning like prolonged period off after a period of working. So we increased how much PTO you could carry over. We increased the maximum duration of PTO for a provider so that if it was right for that person, they planned to do so. They could like plan to save up a little bit and then take a long period off after working here for a few years. So that's an experience I have. And we've talked about like, what does it look like and what does it feel like for a true sabbatical? Like sabbatical, you know, what is a sabbatical for a clinician is an interesting discussion. paid, unpaid, what are they doing? You know, sabbaticals come from the academic world where their role and their funding is a little bit different. So it's all to say, experience, not so much, except for liberalizing our PTO policy a little bit for clinicians that were already asking for the permission to take a sabbatical, like prolonged leave of absence. But opinion, I think they're great to pursue. It's on our list of things in the future to continue to think about as a retention mechanism.
Dr. Malek, there's another question about how you pursue those like nurse after hour positions or the Uber run. So like, is there a contract or cost reimbursement? And the question also asks if you have any advice for clinicians who want to advocate for that kind of thing. Do they do the research and then present it? I know you are in a position where maybe it's easier to present those kinds of proposals.
Sure. So they're both, let me start by like what the programs are and how they're funded a little bit. The after hours nurse triage service is a third-party vendor that you contract with, and you pay them a fee for every phone call they take. So there's the cost with it there, and you can kind of build out that cost and expected cost. The Uber Health is something that we actually just pay to Uber the patient. We as the health center have an account, we Uber the patient to the visit if needed. The financial modeling there is a little bit different for each one. The after hours nurse triage was modeled kind of in our overall wellness budget and thinking about retention benefit and burnout prevention, and kind of the longer term game with that, and also being kind of the ethically right thing to do for our clinical staff. The Uber was a little bit easier because immediately we recognized that the lost revenue for a missed visit because of transportation barrier is high. And so if someone was going to miss their appointment, but instead we paid for an Uber to get them there, we still earn a lot more money by doing that than having them miss the visit. If that makes sense. So let's say, for example, we might get paid $100 for a visit. The Uber costs $10. If they just missed it for new transportation, we earn nothing. If we pay for the Uber and they come, we earn $90. And so it's kind of financially justified and is sustained in that way. With regards to how to make them happen, I come back a little bit to the beginning. It is very challenging to, from the outside in, without an institutional commitment to these, to make some of the changes happen. Doesn't mean it shouldn't be tried, but it can be very challenging if there's not an overall institutional desire or understanding about where you're going with certain things. Within that context, there are certain wins you can make before and without that institutional overall commitment. And I think there are always a couple different ways you can make the cases for something like what we were just talking about. I think it's always important to come with the financial modeling and solution. Personally, I think that really helps negotiating with leaders, and so coming with the knowledge of like what's the financial ask here is because that's often one of the first questions. And then thinking about the moral, like with the why morally or ethically it's important, is also important to come with. And then I would say, like, as clinicians, and if you're a clinician asking this question, but clinicians and people in the clinical space, like compelling anecdotes and stories are also really important for convincing people. Humans respond really well to that. So thinking about a compelling story is also a nice way to approach them.
Thank you. That's really helpful. I know there may be some people listening who are NHSC participants and they may not feel like they're in a position to make those decisions, but that information is really helpful if they want to advocate for implementing any of these ideas.
Mm-hmm. Yep. Okay, next slide. Thank you for the questions. I really appreciate this. It's fun. Okay, so it's 3:40. We have 19 minutes. And we'll do this in about 10 minutes and then have some space for questions, I believe, at the end. So what I want to do is just give you one example of like what following the data and working within our strategic plan looks like. So it's a little bit of a case study here at Thundermist. is particularly with regards to the nurse practitioners at one of our sites. Woonsocket is the name of the town. And so here's some data that we pull out of our annual wellness assessment. You can see some year-over-year data here. So what you're looking at here is a graph that's showing the Mini-Z composite score by provider type and location over time. Ooh, what does that mean? Mini-Z, again, is the Burnout instrument. Just shared it in the link in the chat there. It can be scored numerically on a score from 0 to 50, 50 being like a perfect score, meaning perfectly joyful or no burnout, and 0 being really high burnout. And so the higher the score, the more joy in practice, the lower the score, the more burnout. And the numerical score is nice because you can follow it over time and compare it internally and nationally. Then within this graph, what you see is the blue bars are 2020, the orange bars are 2021, and the green bars, they're blacked out here, or whited out, I guess they are here, are 2022. We'll see later. So what we saw in 2021 is that just looking at the graph with eyes half closed, there's a couple pretty high ones. High joy in practice down here. It's one of our sites that we're very proud of. Bunch in the middle, and then 2 years in a row, way down low on this left side in the red box are these 2 bars. And that is our group of nurse practitioners at the Woonsocket site. And we said, that needs attention. There we go. Let the data show us, like, we know we need some attention there. Next slide. So we dug in within that Woonsocket nurse practitioner group, did some focus groups, some key informant interviews, and what we heard over and over was that these were generally new nurse practitioners. They were feeling very overwhelmed, unable to use the system, kind of lost in the system, pretty alone and unsupported, and often said things like, when I started or when I stopped my training, I just fell off the cliff, or I felt like when I started, I just jumped into the deep end. Next slide. And so within that 3-part approach that we have, clinical leadership, efficiency or practice, and community, we said, okay, like what can we do here? And we worked with them to bounce off some ideas and create a little plan. So one was clinical leadership. So again, people were kind of falling into the deep end. And so we started a mentorship program for new clinicians. So traditionally, we were like most places where you'd start a job and then like occasionally maybe meet with your supervisor if things weren't going well, but there was no intentional way to support them with a mentor. And so we paired one-to-one our new nurse practitioners, new clinicians, with a medical director with a similar clinical interest, and then budgeted mentoring sessions with block clinical time, 30 minutes weekly at the beginning, and then spacing every 2 weeks, every month throughout that first year, for them to have a designated person to work with on integrating both into the health center, but also into clinical practice, since many of them are new to practice. Next slide. And then efficiency of practice, there were a couple items that came up. One was better job crafting. Most of our NPs were just full-time clinical, and frequently came through that was quite grinding to them. And we realized that we hadn't job crafted as well for this group as we did for others. So one example of something we did was we made these hybrid positions, as we called them, where instead of doing 40 hours of primary care, they might do 20 hours of primary care and 20 hours in our urgent care or convenient care. And by creating some more balance, we've had some success there. For a variety of reasons, our NPs hadn't really taken up the scribe program much, so we promoted that and got some more uptake of the scribes in this group. We enhanced the orientation. So some of the things I mentioned before about leveraging that big care team in that chart came out of this. And that's really where this was motivated by primarily. And then we standardized and lengthened the ramping schedule. What that references that at our institution, when you're new to Thundermist, you don't just start your first day with 20 patients or 20 patient slots. You don't just start at a full schedule. Gradually over time, you build up to a full schedule. And so we recognize that ramping, like how fast you can build up to a full schedule, should vary based on your previous clinical experience, perhaps your previous training, etc. And it was happening pretty variably, not that organized, not that consistently. It was kind of up and down. So we standardized it. We made things that everybody agreed would be more likely to succeed, and lengthened it quite a bit, so that particularly our new nurse practitioners had a longer, slower start to their clinical experience to allow them to not just quote fall into the deep end. Then last, community. The other thing we kept hearing in community for our new nurse practitioners was that all of the leaders were physicians, and that was true. And they felt like they didn't represent their interests or their experiences or their background, and were really looking for some community within the nurse practitioner group. So when we expanded our clinical leadership team, we hired our first nurse practitioner medical director, who then took over their nurse practitioner team meeting, and really has improved the sense of community within that group by having someone kind of like to them that can really relate and respond to their needs. Next slide. And so how has this turned out? Happy to say very well. So same graph as before, higher being more joy in practice, lower being more burnout. Same groupings, and that left-hand side here is that Woonsocket nurse practitioner group, where we saw the very low or kind of high burnout scores for the 2 years in 2020 and 2021. And then most recent year of surveying, 2022, we saw a really nice improvement in that burnout score, higher being more joy in practice and more in line with kind of our health center average. So that's just one example of letting the data show us where there was a real hotspot needing attention, digging in a bit, creating some system change, not just simply considering it like a failure of that clinical staff, and then gratefully some nice improvement as a result. Next slide. Okay, that's the end of the content. There's just a few unsolicited tips. One is getting recognized is great and can be a great motivator to that question about like, how do you get people to do this? Generally speaking, people love recognition. And so saying, oh, if we do these things, we can get recognized, can be a big motivator for some organizations. So the AMA Joy in Medicine Health System Recognition Program is one way, the only way I know to do that. I'd encourage you to explore that if you have a larger healthcare organization. The link is here on the slide. Next slide. Second tip I'd say is just don't reinvent the wheel. As you've seen in this series, there's lots of really smart people who have done a lot of work on this, and it's been tried many times. And there's roadmaps to follow. So don't reinvent the wheel. I actually, when I was preparing for this, noticed that there's also even a roadmap on the site where you're coming to these links. There's a beautiful guide to developing organizational resilience from HRSA and National Health Service Corps, which is great. It's very similar. They're all quite similar in content and strategy. There's that one. There's this Joy in Medicine Health System Roadmap, which is great. And then there's this book, this Mayo Clinic Strategies to Reduce Burnout, which is a lot longer and a lot more detailed, but provides a lot of structure. Just do this and like, it'll be good. So don't reinvent the wheel, like really lean on what people have done before. Next slide. And then you're here, you're doing this series, that's phenomenal. If or when you want to take other steps, if you're a clinical leader in particular, there are some kind of certification or higher level training programs regarding leading for clinician wellness. There's this one through the American Academy of Family Physicians, which is the Leading Physician Wellness Wellbeing Program. It is currently free. It's like a year-long seminar and applied practice series. And then Stanford Medicine has a few different programs, one for chief wellness officers and then one for kind of more middle management well-being directors, which the link is for there, but are really well received. Next slide. And then last, I'd be remiss to say that after all this and all the difficulty of promoting clinician wellness, I always have to and should remind myself that our clinician wellness plan really should be the workforce wellness plan. And though I'm really happy that now the conversation is active and abundant about clinician wellness and clinical staff wellness, the wellness of our nurses and medical assistants and receptionists and the whole workforce that's part of healthcare is really important. And I'm hopeful that as we continue to grow in the clinician realm, the workforce also starts to get the attention it deserves. Next slide. Yes, that is the end. Okay, great.
Does it look black on your screen?
It does look black on our screen.
Okay, yeah, I think it's not supposed to be. I'm not sure.
It's not supposed to be, but that's okay. It'll do. It's going to say a thank you slide and a question and answer is what we were looking for here. But that's it. So thank you so much. We've made it through a long time. I hope this was useful as we think about, again, concrete, pragmatic ways that this can be implemented in an FQHC or in your clinical setting. My contact information was in the chat earlier and is in the slide deck if you look at that. And again, don't go this alone. Like, there's lots of allies out there. I'm really happy to discuss or be a resource if you ever want one. And with that, I welcome questions or comments or anything else before we wrap up.
Thank you so much, Dr. Malek. I'm really sorry for the technological difficulties today. That was our first time losing power in the middle of a webinar. So thank you to everyone who's been so patient. And I will try to pull up the slides in a minute again as we start Q&A. I wondered if you could share briefly how the medical director of clinician wellness clinician wellness position came to be for folks who don't have that already at their organization.
Yeah, it came out of, first was the institutional prioritization and of clinician wellness. And part of that, like in the strategic plan and the annual wellness plan, like 1 year, or not the annual wellness plan, the annual plan, like 1 year, the next strategic step towards promoting clinician wellness was to design this position, recruit and hire for it. And so this came before I existed at this organization. It came out of the C-suite leadership recognizing that, as with any element of a health center, there needs to be a leader for that area and recruiting for it.
Thank you. That's really helpful. I'm trying to see if we have any other questions at the moment. And we are going to have someone else from the team share the slides. Yes, Sarah, that would be really helpful if you could do that so you all can see the references. We also are going to go ahead and start the evaluation survey so folks can answer the survey while we're having the Q&A. I did want to mention too, earlier when the individual had asked about having an NHSC participant being in a position where they can have more administrative time working on these types of strategies within the organization. We did have a grand rounds in our first webinar series from Dr. Marquand Daywalker, and he was at a FQHC in rural Texas. And during his time as an NHSC scholar, he became a medical director and then eventually chief officer of equity and wellness. And that was through a lot of advocacy from his part and talking to leadership about needing that kind of position. It was like at the very beginning of COVID. And so clinicians were really struggling. And of course, it was difficult before COVID started, but it was even harder once COVID began. And he was able to advocate for those positions. And then they promoted him into those positions, but he definitely still had to work most of his time doing patient care. And then I think he was given like an admin day, maybe half of the day where he could work on those tasks. And if anyone wants to view that webinar, it's on our website in our archived resources. That was the grand rounds in our first well-being series. Thank you, Sarah, for pulling up the question or the slides. Any other questions? Does anyone want to come off mute and ask Dr. Malek a question directly, feel free to raise your hand and we will unmute you. Or again, you can always use the chat box. Dan, I see you came on. Did you have a question or did you want to chime in?
I just wanted to ask you, how did you get into this position? Was that something that was there for you, or you kind of made your own advocacy to get into a space where you could support and continue this program or this new adventure for clinician well-being?
Yeah, two pieces. One is I was a medical director at different FQHC, and in that context got very interested and involved in this well-being work and very passionate about that as being kind of one of the roles that I wanted to have in leadership. And then at this organization, at Thundermist, the organization itself created this position before I got there, and when it was posted and when it became available, I applied for it. So I kind of came into I developed my interest and a little bit of expertise in a different FQHC where I was working, a little bit more grassroots in terms of advocating and creating this type of change, and then was able to jump into this more mature, if you will, mature organization in terms of where it is and the growth and the process of
So just a quick follow-up. I know we're at the end. So what were in the other position where it was a little bit newer and you may not have been as a senior person in that organization, what was that you had that compelled you to ask to keep moving forward for that time period?
Yeah, one of the biggest things that compelled me actually was I do a lot of teaching of residents and medical students. And I had a bit of a crisis of conscience where I kept telling all the residents and particularly medical students to go into primary care because it's the most wonderful thing and you should be so happy in primary care. And then going back to my health center and people being burnt out and miserable in primary care and telling people not to go into primary care. And I was like, wait a minute, what am I telling all these students? And I realized that my place of passion in primary care leadership was about making primary care a place where you really can thrive, and making it a place that really is the right destination for many people that want to do this work. And so that was my big driver, is both the people who are there, but also big picture for health in America and wellness, making primary care a place that people can thrive.
Thank you, Diane, and thank you, Dr. Malek. We are out of time, but so appreciate all of the valuable information you gave to us today. It was really wonderful to hear about what's happening at Thundermist and all of the strategies that you all are taking on to support your clinicians and probably all staff overall. It's helping everything run smoother and more streamlined. So thank you so much for doing that with us today. As you can see, we're showing you the reference slides. They will be available in the PowerPoint slides. So you can look up anything afterwards that was shared today. And thanks again to our tech support team who helped me out. Sorry again for all the technological issues. And just remember that the PowerPoint slides and related documents are available on the webinar registration page, and we'll post that in the chat again. Our next webinar mini-series on health disparities will begin August 16th at 2 p.m. Eastern, when, of course, we encourage NHSC participants and also leadership staff from the NHSC approved sites to attend, and look out for an email in early August from us with more details and how to register. And Dr. Malek, any parting words before we sign off today?
Thank you for being here. Thank you for investing the time in this series. It shows that you're really interested and committed to this, and we are the change. Let's make it so.
I agree. Thank you so much for that positive outgoing message. And that's it for today. So thanks, everyone.
Thank you all.
Thank you.